Dr. Mascarenhas, would you explain why PV develops and what causes it?
Sure. So we now know in 2025 that PV and myeloproliferative neoplasms in general are driven by the acquisition, meaning patients aren't really born with these mutations in their stem cells, but they acquire them. We don't always know why patients do acquire them, but a mutation in a specific gene called JAK2 in a very specific location in that gene leads to overproduction and activation of that stem cell. So it is continuously on and it is continuously producing progenies, kids. Those are the white cells, red cells, and platelets that end up in the blood. And it is a very inflammatory state. So it's continuously emitting and releasing inflammatory markers. And we now understand that a lot of that biology explains a lot of the clinical features that we see. So, for example, the itching, the fatigue, the bone pain, the headaches, those can all be explained in large part by the activity of these cells driven by this point activating mutation in JAK2, which we call JAK2 V617F. Some of those cells in the bone marrow, sometimes they leave the bone marrow, they end up in extramedullary sites. So that means other organs where bone marrow function is not normally taking place, namely the liver and the spleen. So people can develop organomegaly, big liver, big spleen. And that can also contribute to symptoms and signs of the disease.
Excellent. And what roles do the genes and the mutations play? Especially JAK2, but are CALR and MIPL mutations ever found in PV?
That's a great question because we now know that there are three main classic drivers in the MPNs. There's JAK2, which is by far the most frequent, and in PV, it really represents probably 97% of patients will have this point activating mutation. But really, calreticulin and MIPL, the two other mutations, are primarily found in myelofibrosis, primary myelofibrosis, and essential thrombocythemia. So in PV, it's really a JAK2 V617F driven MPN. There are a small population of patients, maybe 1 to 2% of patients, that have an alternative JAK2 mutation, and that's usually in exon 12, what's called the JAK2 exon 12 mutation. So although JAK2 mutation can be found across the MPN disease spectrum, it is almost exclusively seen in polycythemia vera patients.
Thank you for clarifying that. What stage of life is PV most often discovered?
So polycythemia vera can be discovered at any age group in reality, and we've seen young kids, and there infrequently there are specialists, pediatric hematologists that will focus on pediatric MPN. But the median age is probably around 60, 65. So, I'm always careful not to oversell that because you can meet a 30-year-old who has polycythemia vera, and I would never want that to be not entertained as a potential diagnosis because of the age. But if you look at a bell-shaped curve, it's about 60, 65 is the median age.
Excellent. Does it impact men and women differently, or have you seen much of a difference there?
So most studies would suggest there may be a slightly higher frequency of polycythemia vera in men than women, which is the opposite in essential thrombocythemia, the cousin of PV, in which we tend to see more women than men.